the aneurysm. During the last 10 or 15 years, endovascular procedures such as an endovascular aortic stent graft have been developed for treatment of aneurysmal disease. Initially,
what is a stent?
Well, stent, which Dr. McBride can talk about peripheral stents in a little bit, but covered stent graft is a device that is placed up through the arteries in the groin, and once it's released, it self-expands, and what it's designed to do is seal off the weakened sac of the aneurysm so that there's no arterial pressure to the sac. Eventually, the sac shrinks.
So it's like a tube inside a tube. The artery is a tube, and you're putting another tube inside, expanding it and reinforcing the wall, so the wall is sort of reinforced. Is that right?
Well, the healthy wall is reinforced and eliminating pressure to the abnormal, unhealthy wall that gradually expands. The trouble with the stent grafts is that they're not perfected to the point where we can just do one and forget about it. We still have to keep follow the patients a couple times a year with the CT scan to make sure that the sac is shrinking rather than expanding. And unfortunately, not everyone's anatomy makes a stent graft possible. There are certain things, relationship to the kidney arteries, how twisty or tortuous the arteries are, that would prohibit the use of a stent graft.
Aren't they stent grafts initially were sort of used for the high-risk patient, high surgical risk patient?
Initially, when they first came out, that was for the high-risk patient who otherwise wouldn't be able to undergo the open technique. But the devices have become so good now that more and more people are electing to use that treatment rather than the open technique.
So the outcomes are about the same now?
Outcomes are very similar, yes.
Good. Is there any special other things that the patient needs to do, like take special medications or have other treatment besides receiving a stent, to say, or open surgery for this aneurysm?
Well, there's no medications that will take care of an aneurysm since just the procedure itself, but taking an aspirin a day, it does help prevent clots in any type of an arterial treatment procedure. And of course, most of the vascular patients that we take care of nowadays are on statins to lower their cholesterol.
Right. The statins are a group of drugs which we use commonly in all phases of vascular disease to try to lower the cholesterol, and especially the LDL cholesterol, which is so-called the bad cholesterol. And a lot of studies have shown that lowering the bad cholesterol prolongs life in coronary disease and also improves vascular disease in the legs and in the carotids, and as Dr. Beasley said, aorta. So that's a very important type of medication we emphasize. We also want to control a patient's blood pressure, optimize it. Aspirin's important, and also the big deal is cigarette smoking. A lot of patients with peripheral vascular disease and heart disease, unfortunately, are heavy smokers, and one of the main ways to improve their overall condition to prevent more trouble is cigarette smoking cessation. So we emphasize that every day in a hospital because it's such a big, important thing to do. Anyway, let's go to more, Joe, let's go some more to the peripheral vascular side here and go down the aorta into the legs.
Okay. Well, peripheral vascular disease or peripheral arterial disease, we tend to think of it as disease affecting the blood vessels, the arteries in the legs, in that a person doesn't get enough blood flow to their legs to maintain their usual level of activity. This is usually manifest in symptoms such as difficulty walking, the patient's usual distance. Sometimes the patient will actually get pain, typically in the calves, but can be other portions of the legs. Can also just get a feeling that the one leg or both go to sleep, or that the legs, I've had patients say they feel like wood, or that they feel very heavy. And a lot of times that can be caused by blocked arteries to the legs.
How's the best way to detect this if the patient does have symptoms?
Well, when the patient presents with symptoms, a very easy test that can be done that can ferret out a lot of this disease is what's called an ankle brachial index, or a comparison between the blood pressure at the level of the ankle to the arm. Normally the blood pressure in the leg should be higher than the arm, and if it's less, then if the blood pressure in the leg is less than the arm, then that's an indication that, if the patient has symptoms, that it's warranted to maybe do further investigation.
We probably have a blockage at that
Probably
point.
have a blockage, correct.
Then you go on to do other studies. What else would you do next?
Well, you obviously a history and physical exam, and just and have someone examine your pulses and see what those are like, and talk to your doctor about what sort of symptoms you're having. But then other tests that can be done are what's called a CT angiogram, which is injecting X-ray dye in the hand and taking CT scans of the arteries in the legs. A conventional angiogram can also be done.
It's a dye test of the artery.
Which is a dye test of the artery, where we inject X-ray in the arteries down the legs, very similar to coronary angiogram, where dye is injected into the heart arteries. Right. And also sometimes an ultrasound can be performed of the legs to look at the waveforms and what the flow actually looks like to the legs.
And you also use stents like Dr. Beasley does and I do in the heart. Is that right?
Yes. Now, the stent graft that Dr. Beasley uses, that's typically to sort of provide almost a new lumen, whereas the stents that we would use a little bit lower down, or possibly sometimes even in the thigh arteries, would be to hold an artery open to exclude kind of get the plaque or calcium out of the way, and to hold things open. So
right.
It works a little bit differently, but it's very similar to the ones that you put in the heart.
Yeah, we put ones that you used medicated stents at this point, or not?
There are a couple of studies so far that those have, that one that Cook Incorporated had sponsored, and so far those haven't ferreted out. I wonder if it's a little bit different in flow,
anatomy,
and the sizes of the vessels.
Let me explain a little bit. We all actually use stents these days. And stents, as we said, are tubes holding open arteries or opening them up, in our case, usually in the heart. And we do that to improve blood flow into the beyond the blockage to the rest of the heart or legs or aorta. A lot of organs involved in the aorta, of course. And stents have been a real godsend for a lot of us, but do have some, at least in the heart, some potential problems of maybe clotting up. So we need to use medications. You've all heard on TV about ads for Plavix, which is an important platelet inhibitor, prevents clotting. We also use aspirin, very importantly, to prevent clots in the arteries. And sometimes the newer stents have medications inside of them which prevent renarrowing in the area where the stent is placed, so that it's an extra guarantee or preventive measure to try to keep these stents open so they don't reclose. So that's an ongoing thing. Stents are being developed all the time. There's always some problems with them in development, but overall they've been a very excellent addition to our treatment of vascular disease. Jeff, you're back, I hear.
Yeah, back in here in the echo room. Basically, just want to let you know, first off, the patient's doing great, family's all doing good. So I thought maybe we just review a little bit and go back to some of the images we got.
Great.
Maybe I can point things out now since
yeah, we have a human pointer instead of just a word pointer.
I kind of have some free hands now. So basically, the study was pretty much a normal study as far as the structure of the heart, except for the thing that we knew going into this was the potential of an abnormal aortic valve. And again, that valve is bicuspid. And what I'm going to show you is actually in these images, and there's also a little arrow here, but basically the valve, this is the aorta right here, and we're cutting through and looking down on that valve at this point. I can kind of point out some of the structures again now that I can point. This is actually a tricuspid valve over here. This is the right atrium, the right ventricle, and this is actually the left atrium. So there's that septum that divides the right and left atrium again.
That's a hole in the heart place.
That is.
That's the clots go through sometimes.
Absolutely. So that's the hole in the heart place. And this valve, even though it's two leaflets, as you can see, it's kind of divided in the middle where there's a leaflet on each side here. You can see that opening and closing.
So,
normally, it would be like tri-leaflet, where it'd be like triangles, basically.
But the opening's good, and we didn't see much gradient, at least by color flow or by what you saw tonight.
I would agree. I mean, that valve clearly looks like it opens really well, and I'd be surprised if there was a significant gradient in there at this point. We're going to look at another image again so I can kind of go back and show you what things look like, a little different view. We'll go up here, and basically what I'm going to show you here is the same thing again. This is still that aortic valve, just cut on edge a little bit. This is the aortic root. So again, blood flow is coming from the left ventricle being squeezed out, goes through this valve and goes out through this aorta. As you can see right here, the valve clearly opens well. We had a little bit of concern, again, going into this, that there was a significant gradient across that valve, and I think that gradient was a false gradient, probably